the Stroke Center at Loma Linda Medical Center, and also has 8 years of experience in neuro-related care. Her passion is for patient education and community health. She loves to travel and spend quality time with her children and granddaughter. Carrie, thank you for coming here this afternoon to share with us your expertise in stroke prevention. Now the time is yours.
Told me I should probably stand down here so I can see the slides better. But thank you for having me today. Thank you for the nice introduction. And that is a little bit about my background. I'm also a doctorate student right now with Vanderbilt, and one of the passions that I have really looked at over the last 10 years or so in working with the neurosciences is understanding some of the social determinants of health, why certain populations, certain races, certain genetics are more prone to having some of the conditions in cardiovascular disease like stroke. And when we talk about cardiovascular disease, it's kind of all in one, heart disease and brain disease at the same time. So that is a passion of mine. I put a presentation together talking about more of the prevention of strokes, the things that we can really do in our lifestyle and modify to reduce the burden of stroke. And I'm sure many of you have had an experience or a loved one or have seen someone who has been had a really bad stroke, and some of the devastating disabilities that can go with that. We've come a long way in science and technology, and we've got a lot of more innovative treatments, but yet we still see the burden of stroke, and we'll talk a little bit about why. So this is Loma Linda. This is the new hospital we built several years ago, transitioned to this hospital. It's a beautiful place. If you haven't been there, please visit. I've been there for about 18 years or so, and now I'm on the university side. And this is my place of employment. This is where I work as a nurse practitioner. My job is to respond to all patients that present to the emergency department with stroke-like symptoms so that we can evaluate and give early treatment if indicated. And then I round on my patients every day, so it's a very, very busy service line, just like Loma Linda is. Here's a few facts. I always like to start a little bit with this. Stroke is the 5th leading cause of death in the US worldwide. It's gotten better over the years. We're just not quite there. That's number 3 worldwide. This is a worldwide burden, not just the United States. Stroke is one of the leading causes of serious long-term disabilities. Like I said, some of the victims of strokes may have really severe disabilities, and even with technology still, time is really the essence. And a big takeaway today that I want to emphasize is time is brain, and things need to move quickly for rapid decision making so we can help prevent that. And most people in the community can recognize when someone's having a heart attack. So someone that's having some chest pain and shortness of breath, maybe holding their chest, or diaphoretic or sweaty, and activate 911, ambulance comes, they do a EKG and rapidly identify if this patient's having an acute myocardial infarction or heart attack. We're not quite there with stroke. There's a lot of people in the community who still don't know what the signs of stroke are and may delay activating 911 and therefore may not be eligible for treatment because of the delays. So we've got a lot of work to do there. The brain loses about 1.5 million neurons every minute And when someone has a very large stroke, their brain can age up to 36 years that quickly. And those are the big devastating strokes that we see. So time, once again. Majority of strokes are attributed to the 9 modifiable risk factors. And I'm not going to touch all of them, but I'm going to hit some of the main ones. And these are things that we can do to change our lifestyle. Things that we have control over. Every 15 minutes of time that passes, the vessel that is occluded feeding the brain will decrease that patient's functional outcome. So we know that the recovery continues months after someone's had a stroke, and I'll talk a little bit more about that, but essentially the larger the stroke, the higher the disability, the less likely they'll be able to return to the same state they were before the stroke. And then every minute that counts for, talking about my neurons again. I must have emphasized that twice. It must be that important. So time is brain. Just a few more. There is a trend that we're seeing in younger population, the prevalence of young people having strokes that we didn't necessarily either see before or didn't collect the data that supported that, but more and more we see people in their 30s and 40s and 50s. And I think there is still an idea that this is an aging problem. There is increased risk as you get older. However, we are seeing very young patients now that are having stroke-like symptoms, much more than I've ever seen in my career. And the prevalence in this younger population is staggering. A lot of it seems to be associated with those risk factors of hypertension, obesity, and diabetes, even at a very young age. And essentially, we are also looking at different types of race and ethnicities on why certain populations tend to have a higher risk factor. And it's not really well understood. There's a lot of research that's being done out there to try and understand some of those disparities that we see in different ethnic groups, different races. So it's an area of passion of mine that I really am looking to explore. We see strokes in pregnant women. We see them usually around the 3rd trimester and closely after delivery within the first 6 weeks. That's the most prevalent time that we would see them have strokes. And they could be strokes from a clot, strokes from a bleed, so either kind. And I'll talk about the difference. And yeah, we've seen children too. So things that I have not seen in my career, young kids as young as 6 and 7 years old have presented to us at Loma Linda with strokes. And it's not something that generally you think about when someone comes in, a small child, that is really what's happening. We're thinking of everything else but the stroke. But we know now that there are a population that we are seeing now in the very small children. So there's all these stroke centers throughout the United States, and you may have heard that there is a certified stroke center. So if you were to call 911 today, your emergency service provider would take you, if you had stroke-like symptoms, they would bypass a hospital and take you to a stroke center, primarily the primary stroke center. Those have been placed throughout the United States so that you can access care quickly and receive timely treatment for stroke. One of the treatments that I'll talk about is a clot buster. We call it TPA, or we call it T&K. You may have heard of it, you may have not, but essentially it's a clot buster. And it can only be given within 4.5 hours of a sudden onset of symptoms. So if this individual was by themselves and couldn't call 911, that's a lot of times our time delays. Or the symptoms were not super apparent, and maybe they laid down to take a nap only to find out that the symptoms have gotten worse. Most patients arrive to the hospital outside the time window, most of them. And that's why a lot of these stroke centers are at most of the community hospitals now throughout the United States. Now, where we're lacking is in rural settings, because you've got long distances to get to a hospital that can take care of stroke patients, recognize and treat very quickly. So primary stroke centers really are designed to be able to give you that clot buster as quickly as they could. And if you have any factors that would exclude you, obviously they wouldn't give it, but most of the time it's because patients present outside the time window and they cannot receive it. When we start looking at the two top tiers there, this is where we start to get into the advanced treatments for stroke. There are things that we can now do for someone who has a clot in the brain that is causing a large stroke to occur. We can actually go in there and then pull the clot right out. That was something that we could not do 20, 30 years ago. So we have really seen technology and advancement in medicine really help this population when we recognize them and get them to the correct location. And this can be done up to 24 hours. Now, there's a lot of different factors that go with it, but we have seen some remarkable outcomes from patients that do arrive early and their brain is still salvageable because we can get that clot out. So that is Comprehensive Stroke Centers is an example. Loma Linda is one of them. And they are a big center for a huge community. So a lot of the patients will go to a primary stroke center and then transfer to us for higher level of care. And those systems are important to be in place so that they're streamlined and can really avoid any irreversible cell death within the brain itself. Has anybody ever heard of the stroke belt before? It's been around for a long time. It is a true thing. Based on your zip code, your mortality rate goes up just by where you live. And in areas that I have highlighted in purple, and you can see them more pronounced in the blue on the other side there, that's the area that we see some of the highest prevalence and highest mortality associated with stroke patients. And a lot of this has to do with lifestyle, customs, traditions, culture, and it's not so easy to say, okay, nobody can eat that anymore, it's not good for you. When it's part of your lifestyle, it's part of what you grew up with. It doesn't happen just like that. So working with the community becomes really important so that we can implement things to reduce the burden of stroke without taking away the things that are valuable to that person and the community. So something just to think about. All right, so I'm going to talk this through what we refer to as the chain of survival. And you can see there's different levels along the way, and we're going to touch on those. The first one is community education. So we can't get the paramedics or the EMS system to you or your loved ones unless we can recognize what it is first, right? So that 911 call is super important. And I always tell my patients, and I know that your care here is at Loma Linda, but I don't want you to drive down the mountain in 45 minutes because time is brain. We want you to activate EMS. We want you to go to the closest stroke center and get treatment, and then you'll come to us, and we're going to take good care of you. So that's a big message. Now, this is an example of community education. So let's see if this will play here.
Jenny and her grandma then Grandma started to sway. Grandma sounded strange when she spoke, and Jenny had to ask, what if my grandma's having a stroke? I think I better act fast. I think I better act fast. Does her face look a little bit uneven? Does one arm drift down? Is her speech coming out kind of strangely? Then it's time to call 911. Jack and his favorite friends were having lunch in town. When Hank looked up, half his face drooped down. Hank wasn't making a joke, and so Jack had to ask, what if my buddy is having a stroke? I think I better act fast. I think I better act fast. Does his face look a little bit uneven? Does one arm drift down? Is his speech coming out kind of strangely? Then it's time to call 911. Helen and Bob were walking at their favorite time of day. Helen turned to Bob and said, my arm is not okay. Her arm was limp inside her coat, and so Bob had to ask, what if Helen is having a stroke? I think I better act fast. I think I better act fast. Does her face look a little bit uneven? Does one arm drift down? Is his speech coming out kind of strangely? Then it's time to call 911. Stroke can happen anywhere, morning, noon, or night. And every minute after that, more brain cells die. My heroes acted quickly, and so they all have hope. Precious time and emergency care. You can beat a stroke. You can beat a stroke. Call fast for any sign of stroke. It's what you gotta do. Call fast, call 911. The one you love is depending on you. Someone's depending on you. Someone.
All right, that's kind of a catchy tune, right? We can show those to our kids and anybody in the family, and really this is a public health announcement for Massachusetts did this to help get the message out there. This is what it looks like, this is what we want you to do. So that's an example of community outreach and education. Then we get into what we call the primordial prevention. So this is essentially those strategies that prevent from emergencies of stroke, the risk factors. So this is prior to developing comorbidities or conditions that can lead to stroke. And that's what this is focused on. And essentially looking at the population and policies, such as mandating PE in school. So this addresses childhood obesity, keeping people physically active, but also policies in the community. If we're asking, for you to go out and walk a half a mile and then a mile, but you live in a community where the sidewalks are broken or there's high crime, that's not going to translate very well. So that's a part of the prevention model. When we look at healthy early life interventions, so in moms, early breastfeeding for their babies, that has been shown to decrease the risk of obesity and hypertension, for example. That would be an example of those interventions. And then healthy education approaches, so programs at work that do walks on their breaks, they have access to a gym, those kinds of things would address this as well. And then also the social and environmental determinants. What is the access to healthy foods? We tell somebody that this is the food you need to eat, but they have food insecurity and not a lot of money in their pocket, they're not going to be able to make the same choices in terms of getting nutrition. So these are some of the prevention models that we see working in favor of the community to help reduce stroke. Then we look at, this is what American Heart and American Stroke Association put together. It's a little small clip that I wanted to show you, and it talks about a little bit of why some populations are at higher risk, some ethnic groups and some races. So I'm going to go ahead and play this here.
Mary, Lamar, and Sophia represent 3 groups more affected by stroke than others. A stroke is a brain attack. When it strikes, the flow of blood to the brain is blocked. A stroke can cause you to permanently lose speech, movement, and memory. Stroke is the 4th leading cause of death in the United States and the leading cause of adult disability. Stroke occurs every 40 seconds. Mary didn't know that her risk for stroke is higher than a man's. In fact, 55,000 more women experience a stroke each year than men. And women are less knowledgeable about the risk factors. Lamar didn't know that twice as many African Americans have strokes than Caucasians. In fact, they're twice as likely to die from stroke. They are also more likely to become disabled and have difficulty with daily life. Sophia didn't know that stroke and heart disease are leading causes of death among Hispanics. Hispanic people are less likely to know stroke warning signs. Hispanics are more likely to have a stroke at a younger age. But you can control this by understanding your risk. Up to 80% of strokes can be prevented. Stroke is an emergency. Knowing stroke warning signs and acting fast can save your life. Face. Does one side of the face droop? Arms. Does one arm drift downward? Speech. Is their speech slurred or strange? Time. If you observe any of these signs, call 911 immediately. Learn more at stroke.org.
So any of these videos are available to anyone. You can get them off the internet, you can get them off the website. Very informative, and I think they do a really good job kind of putting the message out there. So when we're talking about primary prevention, I do want to say we talk about certain treatment modalities and how we treat different patients, and always consult with your primary provider, because it's really, they're the ones that should be helping you make those decisions on how to manage your blood pressure, how to manage your blood sugar. And we don't want you to take that on by yourself without coordinating with your primary provider. So when I see patients, you know, obviously we want to look at their background, look at their medications, look at their any type of conditions they had prior to consider, rather than just a snapshot in time. You know, just to go buy some vitamin sometime over the counter may not be the best one for this condition, or it could interact with the medicines you're already taking, for example. So just, you want to work with your primary provider. All right, now we're going to look at primary prevention. So what does that mean? This really focuses on preventing that first stroke from occurring. So that means someone has some existing risk factors, and we want to help reduce that risk of those risk factors resulting in a stroke. So we know that most of those are preventable, so I'm going to talk about modifiable, things that we can control. Non-modifiable are things like genetics, race, ethnicity, hereditary, those things we can't do a whole lot. When we combine non-modifiable and modifiable, our risk factors go up. Our risk goes up, I should say. So this is just a snapshot of what some of those modifiable risk factors are, and I'm going to go through some of those. As you can see, it's really looking at heart health, healthy lifestyle, managing some of those conditions, and we're going to touch on a few of those. I always like to show this chart here because as you can see here, it's broken down by risk factors that are more prevalent in women, more prevalent in men, and some that just because you're a woman, female, you do have some risk factors that men don't have. And you kind of heard that video about how more women have strokes. This is looking at some of those things like pregnancy, gestational diabetes, if they had preeclampsia in pregnancy. Are they on postmenopausal on some type of hormone therapy? Those kinds of things independently increase your risk as a female, just being a female. So we just want to be mindful of that. We see the ones that are associated with both men and women equally, and then some that are more associated with the male population. So I always like to kind of throw that slide out there so that everyone can kind of see what are those specific risk factors. Hypertension, by far, is one of the greatest risk or modifiable risk factors for stroke. These are the most recent guidelines. If you can have a good control of your blood pressure, you can greatly reduce that risk. We talk about cardiovascular disease as heart and brain. Essentially, one blood pressure doesn't tell you a whole lot. That's a snapshot in time. We can all have an elevated blood pressure at a moment. What we're looking for is trends. Is it prolonged? Is it over a period of time? Consistent? Even for patients, I tell them, write down your blood pressure at home. Have a log. Do you know that a lot of our patients, when they come to the clinic, their blood pressure automatically goes up? That's a thing, it really is. So a log in home around the same time every day, keeping track of that is a lot more important than that one blood pressure that occurs in your primary physician or provider's office, okay? And then if you're sick, you may have even a higher blood pressure that day, which is why you might be visiting them. So keeping a log will be really important because treatment really is individualized. Lots of different things that we need to consider. And we have to actually look at other things that may be causing it. Maybe your kidneys are having trouble. We want to look at that. Maybe you're developing diabetes. That too can help raise your blood pressure. And so there's lots of treatment that can be done, but it needs to be really tailored to that individual. So if you can see the categories there, feel free to take a picture. Blood pressure categories, the numbers are listed there of what we're trying to keep our blood pressures targeted at. So normal, as you can see, is that top number less than 120, okay? If it's elevated, it's between 120 and 129, that top number, and then the bottom number less than 80. And then we start to look at what we call stage 1 hypertension. If we consistently have a systolic blood pressure, the top number between 130 and 139, or that bottom number between 80 and 89. Then we start to get into stage 2. Stage 2 is that top number 140 or higher, or that bottom number 90 or higher. When we start to see the blood pressure rise and it's high for long periods of time, it can be very dangerous to drop it quickly unless you're having some other problems like chest pain or something else is going on. Because over time, your brain gets set to a higher blood pressure. And so if we drop it too quickly, the brain doesn't like that very much. So it takes tailoring it down over time. So your primary provider might start you on a low dose medication if we've already tried non-medical management like low sodium, exercise, reducing our cholesterol, those kinds of things. And if we're still seeing hypertension, then we may look at starting you on a low dose like a antidiuretic or a water pill and see how you do. We don't want to aggressively bring you down to those low numbers yet because your brain's got to adjust. I hope that makes sense to everybody. Yeah. Okay. So we're going to work on lifestyle and treatment, and then if that fails, go to medication. So hypertension can be caused from, like I said, lots of different reasons, and can result into a stroke, loss of vision, heart failure. That's a high one that we see. You can have a heart attack from prolonged hypertension, kidney disease, and other dysfunctions as well. There are certain medications that we should avoid when we are diagnosed with high blood pressure. We talk about sodium, we want to keep that down, but we also need to avoid things like over-the-counter ibuprofen, because that can raise blood pressure as well. Or alcohol use, some of the over-the-counter cold medicines. It's getting to be cold season again. We may inadvertently pick up a decongestant, and a lot of those raise your blood pressure. So we want to be mindful of that as well. Caffeine is another one. So think of not just the obvious things, think of the little things that we can do to help reduce as well. Smoking, that's another one. Now, whether anybody smokes, and this is all for the community, essentially, we still do have population that do smoke, and that independently is a great risk factor. It's right up there with hypertension. So it doubles the stroke risk. There are different ways that people utilize nicotine and smoking, and none of them are good for us. We're finding more and more about things like vaping that even our young population were using. So anytime that our patients get admitted and they've had a stroke, this is what we screen for: hypertension and smoking, and we put them on treatment immediately because we know that if they don't stop smoking, the burden of stroke is going to go up, and they may have another stroke. So there are treatments that we can do, from therapy, behavior modification, to medications and weaning them off. Diabetes is another one. The incidence has gone up, and we are seeing this in the younger population, in children as well. So there is some theory that childhood obesity may be a contributing factor to developing diabetes and stroke in the future. What happens in diabetes is it's a completely inflammatory process that occurs in the body. Vessels get stiff. You also have the risk of what we call atherosclerosis. Does anybody know what that is? Ever heard of that? What is it? Pretty much, yes. That's exactly what it is. So it is going to be plaque. Plaque can line up the vessels in the heart or anywhere in the body, in the brain. And when you have an inflammatory response like diabetes, that can cause that plaque to rupture or open. And our body says, uh-oh, there's an injury. So it sends all these things to rescue it, and pretty soon it occludes that vessel. That's a stroke. So what happens in a stroke is that vessel stops giving blood flow to that part of the brain, and then the brain starts to die. That's what a stroke is. So atherosclerosis, which is plaque, comes from hyperlipidemia or high lipid cholesterol levels, paired with diabetes, doubles your risk. Does that make sense? So your blood sugar is really important for us to monitor. You have your type 1 and type 2, and when you go to your provider, they should be drawing and running a hemoglobin A1C. And that is a routine test that you should be getting during your physicals. And that will kind of give you an idea, am I normal or am I pre-diabetic? Because once you become diabetic, it's controllable, but it doesn't go away. You will always have diabetes, but it could be well controlled. And that's what we want. We really want to prevent it from occurring in the first place, but we can manage it successfully with lifestyle modification and medication. So primarily, we're going to see this in what we call type 2 diabetes. So they don't have enough insulin, and so a lot of times this is what they develop over time, not the injections all the time that they get if you've got type 1, but type 2, a lot of type 2s can be prevented. So things like hypertension, obesity, sedentary lifestyle when you're not exercising increases the risk of type 2. So some of the symptoms you may see, and this is a good and important information as well, because women present different than men. And they present differently as well when they're having a heart attack. Do you know that? The symptoms are much more subtle, and if you have diabetes, it's even more subtle. Because of the effects of diabetes, they may not have that same symptoms that anybody who didn't have diabetes have. So we want people to be aware of sometimes the symptoms of a stroke are clouded by the disease process of diabetes, for example. So you can see here, you've got a picture. I didn't bring my glasses with me today, so that's why I'm walking up closer. You can see in women, thirst, headache, blurry vision. They may have that tingling sensation in their hands and feet. We call that neuropathy. Dizziness, hunger, and frequent urination. Dizziness is a big one, because dizziness can be a lot of things, but it can also be a stroke, and a stroke that happens in the back of the brain. So dizziness, we don't like you to take lightly. We need to investigate why, and I'll talk more about that in just a moment. In comparison, you can see some of the differences in men and what those symptoms are. So being aware of those differences are going to be important to report to your provider if you're having any difficulty, but recognizing if there's a sudden change, this might be something that warrants being looked at, and it might need to go to the emergency department. Physical inactivity. So physical activity is a big one. Getting out there to move. We want, a recommendation is 150 minutes per week of moderate intensity, so like aerobic, or 75 minutes per week of a vigorous aerobic. So maybe brisk walking versus like taking a class where you're got your heart rate up and you're doing a purposeful, vigorous activity for 75 minutes. But recommendations now is also using small weights, not just aerobic type exercise, but also implementing some strength building exercise, whether it's small 5-pound weight, 1-pound weight, even when you're walking, using that as well. That actually provides nice, healthy heart activity. So we want you to do that several times a week, and if you're doing really good, reach for a higher goal. If you want to get to 300 minutes of moderate, that's terrific, right? So sedentary lifestyle is absolutely something we don't want you to engage in, because that will increase your risk. So getting up and moving is super important for lots of reasons. Cholesterol levels. These are some of the recommendations at this time on where our cholesterol should be. And cholesterol is linked to what I had talked about when we say plaque or atherosclerosis. So for healthy heart, we want that less than 200. If you have a condition like diabetes or you've had a stroke before, we want it even lower. And as you can see, as that number goes up, your risk goes up. So this is something that your primary provider should also be looking at and checking on your annual physicals. So we get our cholesterol levels, and we know that some of this has to do with diet, so what type of foods we choose, exercise, certain medications can actually make it worse, some make it better. And we work to try and reduce the cholesterol level without medications, but at some point, if there is genetics in the family, we're gonna have a hard time bringing down those lipid levels. We may need to put you on medications called statins, for example, to help keep the heart and brain healthy. So things that you can do, alcohol is one we want to avoid. Saturated fats, very minimal of those. Increase your omega-3 rich foods and use good fats in your cooking, like avocado, olive oil, rather than some of the other oils. Just simple things like that can help reduce your cholesterol level. Now, there is an app on your phone, and I'm happy to show you this after the presentation, but this is an atherosclerotic cardiovascular disease app. You can download it on your phone, and it's free. Basically, what it does is you put some numbers in. Ask your blood pressure, maybe ask what your last lipid level was. And then it provides you a stratified risk of, over the next 10 years of you having a cardiovascular event. Some people may not want to even look at it, but it's there, and I just want to make it available to you. Anybody can download it. Like I said, I'm happy to help you after the presentation if this is something that you would like to monitor for yourself. It is an evidence-based tool, meaning that it is supported by cardiologists and our brain physicians throughout the US to look at that risk over the next 10 years of you having a heart attack or a stroke. So I'm going to leave it up there later, and I'm happy to help you with that. Okay. Other risk factors, obesity and sedentary lifestyle. We kind of talked about sedentary lifestyle, but also paired with obesity and looking at our BMI. So that's something that also, when you do your annual visit, that they should be looking at your BMI. So you get a weight, they do your height, and kind of give you an idea of where you stand in terms of the obesity percentage. There is a syndrome out there that's called metabolic syndrome. We see a lot in women, and it has very specific characteristics. And we know that these patients do have an increased risk of stroke. So it's us as providers important to educate our patients on those risk factors. So metabolic syndrome is essentially larger girth around the abdominal waist area, so the waist circumference, in female and men, elevated triglyceride levels. They have the triglycerides, your bad cholesterol, your bad lipids, your low HDLs are your good ones. So you need to raise your HDLs to help bring down your LDLs. Your LDLs are your bad ones. So these patients tend to have higher triglyceride levels, lower HDL levels, elevated blood pressure, and elevated glucose. These patients will have an increased risk, and we know that. We call it metabolic syndrome. Medications that they may put these patients on, everyone's probably heard about Ozempic and all those medications out there. They're showing that this medication does have some heart protection to it, kidney protection, diabetes as well, and obesity. So people are using a lot more often, and now there are options that it's a pill rather than injection. Blood pressure medications, a lot of times these patients need to be on blood pressure medications. Lipid medications like the statins that I talked about, and then glucose medications like metformin, for example. So this is a syndrome that we've identified as a risk for stroke. So our diet, things like the Mediterranean, the vegan diet, the DASH diet have been shown to be preferred diets in heart health. Heart health translates to brain health. So these have been recommendations. They will have less probability of, or less likely to have that atherosclerotic disease. And I put a picture on the end there of what that plaque looks like. So just imagine a vessel in the brain that has that plaque that is sitting in the middle of the vessel like that, on the wall. And that will build up over time. And you can see how narrow it gets. The blood flow can't get through there. And your brain has to have blood flow. So atherosclerosis or plaque is one of the big problems with stroke. And that just doesn't happen in the brain. It happens in the heart, it happens in the legs, it can happen anywhere in those arteries. Atrial fibrillation. So patients that have heart failure, for example, are at high risk for developing atrial fibrillation. And atrial fibrillation is essentially the top of the heart doesn't beat very effectively, so it clots. And when it clots, it sends actually blood clots to the brain and to the heart. Very dangerous. So if someone does develop atrial fibrillation, they have to be on an anticoagulation or something that's going to prevent them from clotting too fast, because that can cause clots anywhere. Atrial fibrillation is a big cause of people having strokes. The problem with atrial fibrillation is when you take an anticoagulation to prevent your blood from clotting, what do you think it can also cause? Bleeding. So bleeding is a big risk factor for patients that have atrial fibrillation and are on an anticoagulation medication. It's like a double-edged sword. You gotta be really careful. And we see this a lot. So safety is a big thing. You don't want you to fall. We don't want you to hit your head. We don't want you to harm yourself, because when you take an anticoagulation, you can't clot very well. And the whole purposes of that is to prevent a stroke. So if the patients have a new condition of atrial fibrillation, you got to work with your cardiologist, and we're going to get you on medications quickly, because it can be a very serious condition. So this is what happens is the little clots that are developing, you know, like when we cut ourselves and we bleed and then it has a little clot there, that's good. Our body's supposed to do that. We give those patients medication so they can't do that. So now they're at increased risk for bleeding. But if we don't do that, you can see those clots just travel up the neck and will go straight to the brain. And it's one of the big causes of having an ischemic stroke. So being on those blood thinners is important, but it also can be very detrimental if there is an injury or not managed well. Hormones, postmenopausal, especially estrogen, can increase the risk of having increased clotting factors. Inflammation and those things can increase your risk. Couple it with other conditions like hypertension, smoking, obesity, migraines. So you want to work with your provider. It's the estrogen alone that can cause this condition, especially in our female population. Now, I want you to, does anybody suffer from migraines, or if ever know someone that has migraines at all? Okay, so more prevalent in women, and we have an internet out there, and a lot of people use the internet, and they'll come report in the emergency department and say, I've got migraines, and they've never had a formal workup. Migraines, certain migraines, can be very serious and actually increase your risk for having a stroke. They're called complex migraines, but it's something that has to be worked up, so we have ruled out other things before we call it a migraine. But I want you to listen to this clip here real quick.
Doctors have determined what happened to that TV reporter. Remember after the Grammys on Sunday in her live report, we couldn't understand what she was saying, and many people thought at first, including doctors, that she had a stroke of some sort on camera, but that did not turn out to be the case, and we do know what happened to her, and David Wright is here with all that. Good morning, David.
Good morning, Robin. It turns out it was a migraine headache, but this is one of those there but for the grace of God moments for any of us in TV news. A stumble on the air that was so awkward, people thought she was having a stroke.
Well, a very, very heavy debatation tonight. We had a very Darrison bite. Let's go to Terrace Chase and look for the head of the pit.
It was an on-air blunder that had people across the country wondering and worrying.
I was aware of, this isn't making sense.
But last night, Serene Branson was back on the air on KCBS talking about what happened.
I started to get a really bad headache. And I was starting to look at some of my notes. I started to think, the words on the page are blurry. And I could notice that my thoughts were not forming the way they normally do.
Let's go to Terrace Chase and look for the head of the pit.
They sat me down on an area right by Staples, initially gave me some water and just, are you okay? Are you okay? And I still couldn't form words at that point. To be honest with you, I started crying right away because I was scared. I was embarrassed. I was terrified and confused what had just happened.
Well,
Okay, so does that look like a stroke? Absolutely, doesn't it? So if somebody ever said they had migraines and they started with this speech, we never want to just assume that's a migraine. We really want to get patient worked up. And we have seen this happen because certain migraines will present like this. But we want to make sure that there's not a stroke happening, because this is exactly what can happen where someone would delay not presenting to the hospital and finding out that they're actually having a stroke. So migraines, we call them migraines with auras, meaning there's something that triggers before the headache starts, which is what she had. Those are the migraines that are at high risk. So if there's a visual disturbance, like see spots before their eyes, if they have numbness to one side of their body, all of that looks like a stroke, doesn't it? They have weakness on one side. Doesn't that look like a stroke symptom? They might have speech difficulty, just like you saw Serene Branson. On the air, suddenly, she couldn't speak. So these types of migraines can double the risk of having an ischemic stroke, and they need to be worked up. If someone has a migraine, the first thing I ask them, is this migraine acting like every other migraine you've had? Because if it's not, we're working you up. Because they don't just suddenly change. They're usually the same pattern. So migraines is a red flag, and more often we see them in women. So there are treatments that we can do to help prevent and also treat those acute migraines. There's some things that we can do out there now. But we just want everyone to be aware that there is a risk of stroke with certain types of migraines. And I believe this is my last risk factor I'm touching on, is sleep apnea. Sleep apnea can actually cause an inflammatory response to occur. And anytime that your inflammatory response happens, your body reacts to it and it sends things to rescue. Just like with the plaque inside the vessel, it can send platelets and clog up a vessel. And so if this patient has sleep apnea, there are things that we can do. Weight loss is probably one of the biggest ones. So a lot of times when we're not sure, I'll ask the wife, does your husband snore? They usually know. Because if they do, then they may need to be worked up for sleep apnea. And there's treatment we can do for that as well. So all of those modifiable risk factors are things that we can do something about. Non-modifiable means we have less opportunity to do so. We might have hereditary or genes. But let's say everything has come to this day where I think our loved one is having a stroke. In the chain of survival, that is recognition and activating EMS. Doesn't matter if you're not sure. It's our job to figure it out. And we can't do that at home. We have to see you. So we want you to come in. We want to look at your brain and take images, but we got to get you there. So some of the technology now, these are stroke mobiles that come to your home and actually can screen your brain. This is kind of where technology is going. We're not quite all there yet, so we still want you to call 911. TIAs, has anyone heard of a TIA before? TIA is what's referred, we often call a mini stroke, a warning sign. So even if your symptoms are getting better, we need to see you because we need to work you up to see why did you have that TIA in the first place. So a TIA is a temporary obstruction of a vessel in the brain. So you have the symptoms of a stroke, but it resolves. And it is a great predictor of you having the real stroke. So we need to work you up and figure out why that happened so it doesn't happen again. Does that make sense? So 2 types of strokes I'm going to touch on briefly. The ones that cause clots, that's 87% of all strokes. That's the most common. There are also strokes that occur from bleeding in the brain. That's not from hitting your head when you fell. That means that you suddenly bled in the head for some reason. Number 1 cause, hypertension, and then maybe you fell and hit your head. So if someone has stroke-like symptoms, the first thing we're going to do is a CT scan of the head to see if there's bleeding in the brain. Super important. Most of your strokes are caused from clots, atherosclerosis, or a clot from atrial fibrillation that goes up to the brain. And this is how we recognize it. We've already seen the video. This is what picks up the majority of strokes is using that mnemonic FAST. So a sudden droopy face, a sudden weakness on one side, a sudden difficulty with speaking, any one of them. You don't have to have all 3, just one. You call 911. Now, see where the red part of the brain is? That is the majority of strokes. That means weakness on one side. The stroke is happening on the opposite side of the brain. So if my right side suddenly goes weak or can't move it, the stroke is happening on the left side of the brain. My language centers are on the left side of my brain. So I might be trying to tell you something, but the words come out like a word salad, like you saw Serene Branson. She knows what she had to say, but her brain couldn't process it. This is what happens with stroke as well. So it doesn't mean that they don't understand sometimes. It means that the part of their language center has been affected. So it sounds bizarre. That's a big red flag. Now, in the back of the brain where it's blue, this is more subtle symptoms. but has oftentimes a missed stroke. These are sudden loss of vision, even like a little hole in their vision, meaning it's a black spot somewhere in their visual field, or they suddenly become unbalanced. Sudden onset, loss of vision, or can't walk because they're unstable, red flag. We gotta see you. We wanna see if you're having a stroke in the back of your brain that affects vision and also how you walk. So this is what I was saying on the right side of the brain. These are the symptoms I might have, but my stroke is happening on the left side. If the left side is weak, then my stroke is happening on the right side. If my right side is weak, the stroke's on the left side, I'm probably gonna have trouble with communication. And that's why we use speech as one of the symptoms to be aware of. Now, one of the most important things that can happen is knowing when your symptoms started. If you went to bed at 10 o'clock or your loved one went to bed at 10 p.m., no problem, woke up at 6 o'clock in the morning and had slurred speech, for example. The last time that they were seen normal was at 10 p.m. the night before. When you found them, they were at 6 o'clock. They are not eligible for treatment because of that. We don't know exactly when that stroke occurred. So this becomes like detective work because we want to give every single patient an opportunity to be able to receive a clot buster if they're qualified for it. And one of the top reasons why we can't is because they're outside the time frame. If we can know exactly when it happened, that's a very important piece of information. We end up calling people at the store who witnessed it. We call the family members, anybody that we can to try and find out when did this stroke happen. We only have 4.5 hours to give you that medication or your loved one that medication. So I tell my patients, your medications that you have, the paramedics will bring it to the hospital. Put a phone number in there of who knows you best, because there's a few other questions we have to ask. Did you fall recently? Did you have a surgery? Are you taking a blood thinner? Because some things we can't give it to you if you're going to be at risk for bleeding, but sometimes we don't know this information and we automatically have to exclude you, and we don't want to do that. So I tell them, put your phone number with your medications, and then it'll come to the hospital, because we do a lot of detective work to try and find out. We want to save the brain, get you to the emergency department, get that first picture of your brain, do a good exam, get some lab tests, and every single one of those patients will be admitted. We got to look to see why it happened. We're going to find out the cause. So that's our goal now. So there's little strokes and big strokes. Little strokes have more subtle symptoms. They're more mild. When we have a really bad stroke, the one on the side, on the left side of the screen there, look at how much brain is not getting oxygen. So you got a clot in a big vessel that's feeding a lot of the brain there. Those are your devastating strokes. So these are the ones that we will put a wire up into the brain with a little retriever and pluck the clot right out. Very successfully. I've seen this. I've seen patients get up right off the table. I've seen patients walk out of the hospital. You wouldn't have seen that 20 years ago. So there are treatments over there, but we still have a lot of patients that aren't getting this treatment, and that's what we need to do. So medication or getting that clot, that's an actual clot from a brain vessel. Can you believe that? The other types of strokes are bleeding in the brain that does not occur from an injury. So it causes usually from hypertension, or you have a vessel disease like an aneurysm, where it's a weakened wall of the vessel, and some people have this their whole life. never need surgery and never even knew they had them. Blood pressure that rises suddenly could pop that vessel and then they bleed. So if that were the case, then they would come to us and we're gonna control that blood pressure quickly. We're gonna give you a special medicine to stop all that bleeding from occurring. And we may actually have to go into the brain and drain that blood out. And a lot of times we have to put a tube in to breathe for you. So patients that have sudden bleeding in the brain have a higher death rate than the patients that have a clot. Things that we can do. These are just different types of strokes that can occur. We can go in there and put a stent in the brain to keep that vessel open and stop the bleeding, or go in there and actually clip off that deformity there. Look at all the people that are part of the stroke recovery. And this is what happens in those stroke centers. It's a coordinated care, and everybody's invited. So you have a lot of people working with you for recovery. And a multidisciplinary team, especially our rehab team, are phenomenal at these stroke centers. They're specially trained, they work with stroke patients. When you come, if someone does have a stroke, what we refer to as secondary prevention is we're gonna do everything we can for you not to have another stroke. That's what secondary prevention is. And I'll just go through this briefly. That's putting you on aspirin, maybe, to help preventing a stroke from occurring. Blood pressure management, diabetes control, all the things we talked about. Anticoagulant for atrial fibrillation again. Or we may actually have to go in and open up that vessel in your neck and pull that plaque out. And that is what we call a carotid endarterectomy. Or we can actually put a stent in there. So you see that little opening there? We can pull that plaque right out, because that could be causing your stroke. That's what it looks like. There's the stent going into the vessel. And then finally, we're going to end with rehab. So rehab is really a multidisciplinary approach to recovery after a stroke. It is the hallmark for stroke recovery. We don't know exactly the effects of the stroke that occurs until several months after recovery. The best outcomes occur when you've got an aggressive and very seasoned or trained rehab team. They are going to help with not only your physical disability, but also cognitive, communication. Also, that get you back to be as independent as you can, despite the disabilities you've had. Help prevent complications, because that can be really high if you're not participating in rehab. Support you psychosocial, very high risk for depression post-stroke, as you can imagine, and help facilitate that long-term recovery. They're a phenomenal team, and what we know is those individuals who aggressively participate in rehab, the brain heals better than those that don't. There is a process that occurs, and that top picture is over time, the brain will reset and have new learning centers develop over time. And the hallmark of that is rehab. So your brain starts to learn to do things that it didn't used to do from that part of the brain, because that part of the brain was affected by the stroke. That's how recovery occurs. And then also support groups. So Loma Linda has a support group. We have a wonderful neurosurgeon who runs that, Dr. Pillai, at Loma Linda. He's back to doing them on campus, and I've gone to many of the meetings and talked with stroke survivors and their loved ones, And the loved ones should be there as well because it's a family that's all been impacted, right? I wanted to really focus on the preventative model, but I can't not mention the treatment and also the recovery for those that do end up having a stroke. So I hope I gave you a little piece of information that you can take home with you for stroke awareness.
Thank you for the information. I have two questions, and one has to do with blood pressure. I know that in my 20s, and being an athlete, my blood pressure was, I would say, out of sight. It was really good. But now at 82, I take my blood pressure pretty frequent, and 132/78. My wife says it's too high, but is that really high for an 82, 84, or 86-year-old man or a person?
So the recommendations are there for all populations, different age groups. So as you get older, your blood pressure tends to go up.
Yep.
That happens with aging. The things that you can do to keep it as low as possible is your best bet. So remember I said your brain kind of sets with your blood pressure over time. But we know through studies that the targets that I put up there are the best targets for blood pressure and prevention of cardiovascular disease like heart attacks and strokes. So.
Okay, and question number two. It's beautiful if what happens in a stroke and the time element and everything else, you're talking about Loma Linda University Hospital. Are all the hospitals available to do that treatment? If not, what can be done so that we do have that same preventive way of preventing something like that Loma Linda offers,
Yeah.
but it's not available anywhere else?
So the good news is it is available, and it is becoming much more accessible over the last 10 years. So when a center is certified, that means they have to meet specific requirements to be certified and have to be able to provide not only certain treatments, but they have to have a method of transporting you to a center for that higher level of care. And we're just one example.
Is that information available to the public?
Yep, it's on the website. You can type in certified stroke centers. Now, I did mention rural environments is a disparity. There are not as accessible. What they have tried to do is work with the air medicine, like helicopters essentially, to be able to transport them long distances, even from here, up in the high desert, like where Victorville is and St. Mary's and Apple Valley. Though they had no stroke center up there for years. So those patients were often flown down to Loma Linda. And just to give you a perspective, there are about 7 comprehensive stroke centers, the highest level, just in San Bernardino County. So that gives you, San Bernardino County is a huge county, right? And even more plentiful are primary stroke centers. So if I'm a primary stroke center and I determine you need higher level of care, I must have a means to get you to a comprehensive stroke center. So that's the good news.
I have a question about your guys' stroke support group. I work at a local hospital, and they're not as plant-friendly as Loma Linda. In your guys' support group, do you talk about nutrition and going a little bit more high fiber and things like that?
So every month, Dr. Pillai has a different topic. And so we have brought in some of our dietitians, nutritionists from Loma Linda Health, and we'll do cooking classes and do have a dietitian come in and talk about, you know, different recipes or what have you. They love it. What we're trying to do is get out in the community, and like I said, there are certain things that are tied with culture, their history, you know, that you just can't say, don't eat that ever again. You know, it just doesn't always work that way. Working with the community to even modify it so it's healthier without improvising anything that's, you know, important to them, like culture, for example, is more important, and you'll have more compliance than. So we talk about that too, is working with the community on how we can enjoy this kind of food made this way and still have the same, you know, flavor and, you know, things that are important to them, essentially. But the answer is yes. And actually, they loved the cooking classes. We even had, you know, line dancing, you know, or some, you know, things where people get up and move.
Second question, do they have to pay to be part of the cooking
No.
class or support group?
No.
And
all
they don't
free.
have to be a Loma Linda patient?
No. We advertise it. If you go on the American Heart website, you can look to see any of the support groups for any of the hospitals. So it's not uncommon to have someone visit, you know, a different facility or come to ours or go somewhere else. They just want to be able to have access and work with other survivors, share their stories, and support each other. Some places have split between stroke survivors and family because, you know, the family grieves a lot too. And so their needs may be different. So some places will have a different support group just for the caretakers, which I think is wonderful as well.
To feed on that question, do you have a specific caregiver support group? Because at the hospital I work at, we don't have one for caregivers, and I know some people that want their own.
Yeah. His one is combined right now.
Oh, okay.
Yeah. I don't know if he's decided to split it, but he's had it combined. So a lot of times it would be a family member that accompanies the stroke survivor as well.
Before you began your talk, you were mentioning that you're seeing a trend in increase in stroke in younger patients. Could you talk about that a little, and what your experience has been? Were these people looking at them, you would expect them to have a stroke or not? You know, if you could just share some of your thoughts on that.
Yeah. So 2017, I think it was about 2017. I started. I was a pediatric nurse. In my early career, it was my background. So I always had a love for pediatrics. And everyone's always asked me, how do you get into stroke? Well, I'm very passionate about stroke. I don't know if it found me or I found them or what. But I started seeing more patients come in with stroke-like symptoms and reading about in the literature. And we had a few cases. So we started not a program, but a process. The problem was pediatrics was based on adult guidelines. There were no guidelines for pediatrics because nobody thought kids had strokes. The same kind of strokes that adults do, like from a clot. They have bleeding strokes a lot, we know that for sure. But, you know, even things like sickle cell anemia can cause clots to occur. They're born with that. So yeah, kids have clots and kids can stroke. But what we found was that it wasn't recognized because it wasn't something you thought about. So a lot of times they would be misdiagnosed or would be unrecognized, only to come back with symptoms again or the results of, because they're more likely to have a seizure, for example, than adults would. So we started seeing that. And I remember in one of the emergency room attendings in pediatrics that I talked to, after I heard a lot of, no, kids don't have strokes, no, you know, it's so rare, He said to me, he's like, I'm just wondering in my 30 years of emergency medicine, how many kids I missed because we started seeing them. And we don't know if we're just seeing them more, we just weren't tracking data before. We just don't know. But we know now they are developing guidelines. So it's not just happening in Loma Linda and San Bernardino County, it's happening all over the US. And so we've had what I was telling you about pulling that clot out of the brain that we did for adults. All the studies are on adults. There are no research studies on kids for obvious reasons. You don't enroll kids in clinical trials for, treatment. They're doing them on kids. And we've had several. One of them I tracked for years, Benjamin, was 9 years old. He was at school. They were playing, like freeze tag, like you stop and you freeze. Well, he froze and fell and never got up again. So EMS arrived and noticed he had a crooked face and he wasn't moving one side, couldn't speak. I had already trained them about it, and they brought him in. He had a massive stroke, big one. And they pulled the clot out, and I interviewed him and his dad after. And Benjamin told me everything. He said, I wanted to talk, I couldn't talk. I wanted to move, I couldn't move. And remembered the whole thing. He was a child that had an undiagnosed cardiac problem. So he threw a big clot from a heart problem. Nobody ever knew he had it. So we always say the stroke probably saved his life. He had no disabilities after that, from the stroke, I should say. But 9 years old. 9 years old. Yeah, I think our youngest is probably 3.
And we know that time is of the essence.
Yes.
Between life and death. So can you repeat to us what is the time limit from the time of the stroke and the time that emergency care call?
Okay. Yeah, so for treatment, there's only one medication that we can give for ischemic stroke. And that is a clot buster. And we can only give it to you if we know you're not having bleeding in the brain. We can't give you a clot buster if your stroke is from a bleed. Does that make sense? We're giving you a clot buster. So we got to get you to the hospital. And the FDA approval on that medication is only up to 4.5 hours. That means from the time that the stroke occurred to actually administrating of the medication. So you have to think it's going to take a little time to get to the hospital. It's going to take a little bit of time to get into the CT scanner to scan the brain. So you really should be there within 3.5 hours. The target for used to be 60 minutes from the time that you arrived to the time that we gave the medication. It is more like 30 minutes. So things happen really fast. Now, so you can imagine 3.5 hours is not a lot of time. That's why it's the #1 reason that we don't give it. But also paired with that, sometimes we just don't know. And if we don't know, we can't guess. So that's why the phone number becomes important, or somebody that can tell us, yes, I saw them at that time and that's when the symptoms happen. The hard ones are when they go to sleep and wake up and had a stroke in the middle of the night. We don't know when that happens. And as of right now, this is probably going to change in the future. They are automatically excluded. Now, that used to be the only treatment for many, many, many years. So you can imagine patients with huge disabilities that only had that one option in that 3.5 hours. Now with the fact that we can actually go up into the brain and pull the clot out up to 24 hours, changed a lot of things for big strokes. You can't do those on little strokes. They have to be in a big vessel. The devices will not fit in a tiny, teeny little vessel as of today. Things change.
You know how like now we have the Apple Watch, we have the Aura Ring and those things that collect biometric data? Could that biometric data in the middle of the night kind of identify when the stroke could have happened to give you that information?
Yeah, it could. I mean, we're already doing certain things like atrial fibrillation is a big one. That's a big one. And some patients don't even know they have it. And what's even more dangerous is if you have it and then it goes away and you have it again suddenly, that's more dangerous than someone who's kind of had it over time with some treatment. Because what happens if your heart's quivering at the top and then it starts to beat suddenly, and that's what spreads all the clots around. So there are devices now that go into the tissue, and it's a Bluetooth, and it's sending to a center that's monitoring. When we suspect that you might have atrial fibrillation, it can monitor you for months at a time and pick up when you've got an arrhythmia. So there are certain things that can do that, because that's a big one of them. Now, it's kind of moving towards, research is looking at extending the time for the treatment. So those trials are underway. And actually, some centers are already looking at that yet. We don't have all the evidence to support it yet.
It's just one more question. You mentioned these special mobile units that have all the equipment necessary. Do they have the capacity to determine that and to administer that blood clot buster you're talking about?
Yes.
Or does that have to be done at the hospital?
It's done right in the scanner, in the mobile scanner.
Amen. Thank you.
So here's the problem with those. They're terrific, don't get me wrong. What's our population in, let's just say, Orange County? Do you know? So there are, you know, at where I work, we run, and not all of them are strokes, because a lot of people come in and they think they're strokes, they end up not being strokes, and yay, we're glad about that, right? We don't want you to assume it's not. So we run over 100 strokes a month. So that is, can you imagine, one vehicle can't hit all those people, and they're multi-million-dollar vehicles. So I think they're great, there are limitations to them. You know, who's gonna benefit? The one who called first? I don't know. It's just, I think more streamlined is EMS. We train our paramedics to recognize stroke and get them to the center. Like I said, they're not gonna take you to a hospital that's not certified. They are trained, and their protocol is bypass this hospital and go there. Yeah. Yeah.
Thank you, Carrie,
You're welcome.
for spending your precious time with us.
Absolutely.
this
It's my
afternoon.
pleasure.
And I think by now we are aware that stroke prevention is so crucial to our daily life.
Absolutely.
Thank you.
You're welcome.
This is our token appreciation
Oh, thank
for you to come.
Absolutely. Thank you. Okay. Okay. Sure.
Let me go to prayer.